restoration of coronary blood flow at cardiac catheterization. I was talking to one of the interventional cardiology. The youngest case they did stenting or para matanggal yung thrombus was 5 years old. Then also they are recommending also a bypass surgery for a 10-year-old child with Kawasaki disease. Okay, he's now having giant aneurysm. Okay, so in other words, we can do it in our country. Now, thrombolytic agents should be administered together with low-dose ASA and low-dose heparin with careful monitoring for bleeding. So you need to monitor the PTPA. And the treatment of coronary artery thrombosis with substantial thrombus burden and the high risk of occlusion with a combination of reduced dose of thrombolytic therapy and Joraximab may be considered. Now, these are the causes of death in Kawasaki disease. For the acute phase, heart failure, dengue shock, myocarditis, proceeding to severe heart failure and dysrhythmia. We have one patient who had VTAC and eventually died during the acute phase of the Kawasaki disease. For the subacute phase, same as stage 1, however, your MI and aneurysm rupture can occur in the subacute phase. And in the convalescent phase, usually it's MI. Okay? So this just shows you the Kawasaki disease with coronary involvement. It can be aneurysm, scarring, stenosis, calcification. And the most frequent locations is your left main coronary artery, which is difficult to see sometimes. And 50% progresses in 1 to 2 years. Okay, and the long-term implications is questionable. Okay, now, I'm nearing in my last few slides. Okay, now, how about your long-term management for prophylaxis and careful surveillance of coronary artery stenosis? Okay? So, medical therapy for myocardial protection. Patients with coronary artery aneurysm after KD may merit medical therapy to minimize the risk for and the degree of myocardial ischemia. Okay? First, the medical intervention can be considered in 2 roles: avoid MI and death, and second is controlling chest pain and other ischemic symptoms. Okay? So, aspirin low dose. Remember, aspirin breaks down into acetic and salicylic acid, and the acetic acid irreversibly binds to COX-1 within the platelets, preventing the formation of thromboxan 2, which is a potent vasoconstrictor and induces platelet aggregation. This now results to a decrease in the ability to form clots and decrease your bleeding time. The recommended dose again is 5 milligrams per kilogram. How about your clopidogrel, which is Plavix, available as Plavix? The active metabolite of clopidogrel selectively inhibits the binding of the adenosine diphosphate to its platelet receptor and the subsequent ADP-mediated activation of the glycoprotein complex, thereby inhibiting the platelet aggregation. The dose is 0.2 milligrams per kilogram. Okay? So, aspirin 5, clopidogrel is 0.2 milligrams. Okay, beta blockers, okay? You may give your carvedilol, metoprolol for patients. Beta blockers will be considered for patients of all ages, particularly those at high risk of myocardial ischemia because of large or giant aneurysm. Like the patient of Cora, whom we are treating, who na-admit dati. Bubuhay pa naman siya, 2 years na. Ito yung pasyente ito, nag-hospital hopping, okay? Beta blockade decreases the risk of MI and death by reducing myocardial oxygen demand. And for atherosclerotic disease, beta blockers are a critical part of management, and their effects should extend to the pathophysiology of KD coronary disease as well. So you can give carvedilol, propranolol, okay, Inderal. Then also you can give ACE inhibitors, okay, renin-angiotensin-aldosterone blocker. And also you can give statins, which is your 3-hydroxy-3-methyl-glutaryl coenzyme A reductase inhibitors, which may decrease the inflammation in post-acute Kawasaki disease complicated by coronary artery aneurysm and promote vascular remodeling. So, pwede yung sa bigyan ng mga statins. Okay? Now, I would just like to show you the risk stratification. Medyo toxic po ito. Okay, they have the risk level for Kawasaki disease. Okay, you have the no involvement, you give low dose ASA, wala kayo ibibigay ng anticoagulant. This is just for 6 months, provided you have a normal ESR, CRP, normal platelet count, and normal, what's this? to the echo. However, if after 2 years the patient is having chest pain, the next thing you have to do is refer for computed axial tomography in the neurocenter. If the patient has dilatation only, combination of after 6 to 8 weeks is reasonable. If the patient has small aneurysm, current or persistent, continue the aspirin, and during give warfarin. You can give also ASA plus clopidogrel, and also consider giving statins. If small aneurysm regress to normal and dilatation only, okay, continue giving aspirin and consider statins. Medium-sized aneurysm, current or persistent, continue aspirin, okay? You can give your anticoagulation, warfarin, clopidogrel plus your statins. Take note that the beta blocker is only given for patients with giant aneurysm. Okay? Again, tuloy-tuloy pa ng aspirin. Clopidogrel is given. Okay, then you can give statin. So, isipin mo, ang daming ininom na gamot ng bata. Pero kailangan po yun para wag siya mag-myocardial infarction. Okay, this is the long-term assessment and counseling algorithm. So, we need to see them frequently because we need to give counseling, particularly in sports-related activities. 2 weeks ago, I had a patient, dami pong sports clearance ngayon, lalo sa Laguna, yung mga taga-Lasal, kasi required sila na sa cardio ang clearance. There was one patient, Kawasaki disease. Sabi ko, I need to do some workup. It turned out, meron siyang giant aneurysm sa peripheral artery. So, I deferred the sports clearance. Now we are referring the patient to Philippine Heart Center. So please, be extra careful in getting your history. If you will check the sports clearance history of the American Academy of Pediatrics, one of the questions, the 42 questions is, did you have Kawasaki disease before? Okay, now this is the summary of treatment, okay? So give IVIG 2 grams single infusion for 10 hours. Okay? Then ASA at 80 to 100 mg per kilogram in 40 divided doses until ephemeral for 2 to 3 days. Then you give ASA 3 to 5 mg per kilogram once daily for 6 to 8 weeks. Okay? If fever persists after 48 hours or recrudescence of fever within 2 weeks, you give a second dose of IV gamma globulin or nasa high dose of pulse steroids for 3 days. Then methylprednisolone 30 mg per kilogram IV daily for 1 to 3 days. Inflammation. Or you can give infliximab 5 mg per kilo, may be considered as an alternative to a second infusion of IVIG or corticosteroids for IV-resistant patients. Then cyclosporine may be also considered in patients with refractory Kawasaki disease in whom second IVIG infusion, infliximab, or a course of steroids has failed. And also the last is inhalatory mononuclear antibody therapy, except tumor necrosis factor, alpha blockers, cytotoxic agents, or rarely plasma exchange. Okay? I remember Dr. Ariel has a referral to me in Gen 3 doctors. Ang mahal ng IVIG plus the hospital will add 30%. So in other words, yung 19,000 IVIG mag-add pa ng 30% hospital. So sabi ng parents, Doctor, wala po kami, pero uwi na lang po kami. I was so worried. What I did was I gave methylprednisolone. Okay? Yung binigay ko instead na IVIG, okay naman siya. The patient followed to me last week after 1 year. Okay siya. Pero gusto ko pa rin siyang computed axial tomography kasi I'm not happy. I'm not sure if there is coronary dilatation in the distal branches. So, fellow pediatricians, okay, these recommendations provide an updated and best evidence-based guidance to healthcare professionals, providers to diagnose and manage Kawasaki disease, but the clinical decision making should be individualized to specific patient's circumstances. So, Kawasaki disease is a big challenge. I always tell the pediatricians, anybody, even FAMED, can take Kawasaki disease, but we need to do a baseline echo. Kung complete Kawasaki disease, wala pang pera, sige, we can do the 2-day echo at a later time. But if it has a giant aneurysm, aspirin is not suffice. We need to give clopidogrel and we need to give warfarin. Okay? But I am not comfortable managing a patient with warfarin. I usually refer a patient to a hematologist because the patient can bleed anytime. And also, warning lang, baka po may myocarditis yung mga pasyente nyo, pwede silang fatal arrhythmia. They can go into ventricular arrhythmia and then suddenly they die. Kaya po kasi baka balikan kayo, Doktora, yung anak ko po nag-Kawasaki, namatay po siya kagabi habang naglalaro. Baka po nag-myocarditis yun, then suddenly what's this? Nag-fatal arrhythmia. I had a patient who was Kawasaki, mga 16 years old. Sabi ko, baka maglaro ng basketball. Suddenly, I got a call from the mom. Namatay po habang nagbabasketball. In lack of shooting, suddenly fell and the patient died. DOA upon arrival to the hospital. Sinagot ko na lang, most likely po, nag-myocarditis yung anak nyo, okay, nag-arrhythmia because of the myocarditis secondary to Kawasaki disease. Okay, good afternoon. I just hope you learned a lot from this lecture. Thank you very much.